pain. She's had pain for about 3 years. And when we look at her x-rays, we see that she's got a little bit of lateral compartment wear. She's got a little bit of patella alta. MRI shows that she's got some central and lateral wear. And when we do the measurement, she's got a elevated TT to TG and a patella alta. So when I think about this patient, what I usually like to think about are all the different options for her. First of all, I think it's important, oftentimes these patients will respond just fine to benign neglect, especially if it's an incidental finding. And like the last talk mentioned, if they have a meniscus tear as their predominant symptom and they have no patellofemoral pain, there's no reason to treat this. I'm gonna focus this talk on non-operative management, although to be honest, even though I'm gonna talk about biologics, I think the most important part of the non-operative management skill set is a good rehabilitation and good physical therapy. Now, we've all heard of PRP, or platelet-rich plasma. It's gained a fair amount of both good and bad press, and more it's being shown to be used for absolutely everything. Everything from dry eyes, musculoskeletal condition, and even better self-esteem, which it probably doesn't work for. When you think about using PRP, I think it's important to understand that all PRPs are not the same. When we look at different companies, each company has its own special proprietary system, which it adds different concentrations of platelets, different volumes of blood, and different spin cycles to allow different overall effects of PRP, which is part of the reason why the studies are so hard to figure out. Now, we don't understand exactly how PRP works, but we know that most likely it works because it has a huge concentration of growth factors, many of them good, including TGF-beta, PDGF, insulin-like growth factor, but it also has a variety of not so good growth factor inhibitors that in concert work to modulate various biologic effects. One of the most important things about PRP is that the actual amount is not consistent. The final platelet and growth factor concentration that you get is dependent on the amount of whole blood used, essentially how much of a blood draw you did, the efficacy of platelet recovery, which is variable between systems, and the final volume of plasma in which the platelets are suspended. I think what's really important is that PRP can vary from day to day, even in the same individual. This was a really nice study that was done by Gus Mazaka's group in the University of Connecticut. They took 8 subjects and they did 3 repetitive blood draws. And I'll put your attention to this part here. This is one patient and he had a 3-fold difference in his platelet concentration over a single day. So the cell counts individually are going to be inconsistent from day to day. And this has considerable implications because PRP is often recommended to be given repetitively. And even within this, there's considerable biologic variability in how many growth factors are within each platelet concentration. So when I think about how we use PRP, I like to think that we're going to use a combination of the best external evidence, basically the evidence that we're provided, what's important for the patient, for example, is pain relief or a biologic solution important, and then use our best clinical judgment. So there's not a lot of data on whether or not PRP actually works for patellofemoral pain, but there is some decent data that shows that PRP is pretty effective for general osteoarthritis. This was a nice study out of Rush where they compared hyaluronic acid to PRP, and even though their primary outcome was looking at WOMAC scores where they found no difference, they did see that there were differences in their sub-analysis, including an improved IKDC scores from month 6 to 12, and it seemed to work better in patients with mild OA and lower BMI. So they conclude that there are significant improvements in patient-reported outcomes with results favoring PRP over hyaluronic acid. And this has been shown in a variety of other studies well. This was a study that just came out in AJSM. It's another randomized controlled trial. And what they found in this group was that it works well for all areas of the knee. So it worked well for patellofemoral disease. More patients reached the MCID, minimally clinically important difference with PRP compared to HA. but there was no overall statistical difference in outcomes. Now, interestingly, what they found was that within the PRP group, the concentrations of platelet-derived growth factors were higher in the patients that did well. And you remember from this slide a few minutes ago, this is particularly important because basically what it means is if you get a good delivery of PRP and growth factors, it's going to seem to work, but it may not actually work as well when you don't have those growth factors at such a high concentration. So what I tell my patients who are asking about PRP is that there's level 1 and 2 evidence that it is absolutely and completely safe. The side effects are very low. It's likely probably beneficial for pain relief. The effect size overall is relatively small. It's not going to absolutely change your knee, but it may make you feel better. And we have no long-term data on the natural history, whether or not it'll actually prevent or delay any other surgical treatments. And I tell my patients that it's not promoting cartilage growth, it's promoting pain relief. So what about biologic strategies for patellofemoral cartilage loss? Now, my decision to whether or not to treat cartilage, I like to think about whether or not I can treat this problem with an alignment correction alone. Essentially, can I do this with just a tibial tubercle osteotomy? Do I need to add a stabilizing procedure, especially if in the setting of trochlear dysplasia? And do I need to add cartilage restoration, or essentially something to rebuild absent cartilage? Now, for the most part, there are a variety of cartilage options. I really don't favor using microfracture in the patellofemoral joint. Osteochondral autograft, I think, is rarely used, and I've only used it once or twice. I'll use osteochondral allograft for patients with bone loss as well as cartilage loss. And for the most part, my go-to is matrix autologous chondrocyte implantation, or MACI. There's good evidence that MACI is probably a decent treatment option for a variety of different reasons. First of all, when you compare microfracture, which is often our first go-to, it's easy, it has no incisions, to MACI, which is a much bigger, much more expensive procedure. This was a really nice study recently out of Spain that came out in cartilage. It's a small group of patients. It's only 10 MACI patients and 7 microfracture patients. But what's unique about this study is they not only have clinical outcomes, but they also have cartilage fill with T1 row and T2 mapping. And what they found is in the MACI group, there's a significantly better improvement in knee outcome scores. The lysome score, Kujala, IKDC are all improved. The KOOS pain and function scores are significantly higher, and they're doing much better in quality of life and sports performance. So this study suggests that MACI is probably the dominant strategy for isolated cartilage lesions in the patellofemoral joint. Most MACI procedures are done in the tibial-femoral joint, and most of them are on the medial or lateral femoral condyle. And this group out of Australia with Jay Ebert have looked at their cohorts in a variety of different ways, but this was a really nice study that came out a couple years ago. They looked at a comparison of 2-year outcomes in patients comparing if they had a tibial-femoral MACI or a patellofemoral MACI. And what they found was overall, both groups were doing really well. At 2 months, over 90% of the patients were satisfied. Their pain relief overall was excellent. Most patients were back to participating in sports, or at least a majority of them. And the overall composite score was classified as good to excellent in a vast majority of the tibial-femoral and patellofemoral patients. So we tend to think about MACI as a really good strategy for femoral condyle lesions. It's probably just as good of a strategy for patella and trochlear lesions. I think the other advantage for a MACI is that it's a staging procedure. It, by definition, takes 2 procedures because we have to harvest the cartilage and send it off to the lab. I think oftentimes our MRIs will underestimate the size of the cartilage lesions. And I think it also gives us a chance to understand our patient a little bit better, understand their goals. There is a chance that some patients will respond to debridement alone. In my case, in my setting, it's only been about 10 to 15%. But it does allow me to plan a little bit better and have a more comprehensive plan, especially for complicated procedures that involve the patellofemoral joint, where and exactly how much of an osteotomy I want to do. So thank you.